many things that he does. But welcome, Wes. We're glad to have you. Appreciate all you've done. He meets with the ministers by Zoom for pretty much for the last 16, 18 months every Monday. So that's where I've met him, camera. But we're glad to have him. He's willing to mention to us faith organizations. Thank you so much.
My
We're
pleasure,
glad
Ken.
to have you.
Thank you. Well, let me just tell you a little bit about who I am, and hopefully encourage you to ask questions through that introduction. I am adjunct professor of emergency medicine at UNC Chapel Hill. So what that really means is for more than 30 years, I taught and supervised physicians in training in the emergency department at the University of North Carolina Hospital's emergency department. I'm also a medical officer in the National Disaster Medical Service. So that's sort of like a non-military National Guard. Sometimes people know us better as disaster physicians. So we are deployed by the federal government when there is a large disaster. And we have special training to deal with numerous kinds of disasters, but they will deploy us to things like, I guess the most frequent thing I've been to is hurricanes. But we also go in to relieve hospitals that are just overwhelmed by COVID. We have been called to earthquakes, to really large fires that are threatening a large area. So that's the kind of work that we do. I'm actually on call this month. I'm surprised I'm able to be here now. I thought they would have called up. I'm based with a team that's in the triad that's called North Carolina 1. So some states have more than one disaster medical assistance team, but we just have one in North Carolina. So the other hat that I have worn recently, I was medical advisor for the state emergency medical services as we were gearing up to get ready to deal with the onset of COVID to help them develop some strategies and choose equipment that would serve our citizens well. So that's my background. Much of what I do is just keeping up with what's happening with this pandemic and trying to figure out how to keep people safe and trying to help disseminate knowledge that's based in science. So I hope you will all feel free to ask questions. If not, this could turn out to be shorter than we had hoped. But there is just one thing I want you to remember. Hi, welcome. There is no such thing as a stupid question. If you've got a question, there's a really good chance that someone else is thinking that same thing. So I'm happy to answer those questions. Rather than to give you a speech that probably wouldn't be interesting, I thought it might be more productive just to dive in and see what questions you have. I know I've gotten some questions that Craig forwarded to me, and I'd be happy to talk about those as well if they don't come up in your questions. But what can I answer for you today? Well, in the past, UNC has gone to a policy which doesn't allow elective procedures like elective surgeries that need to be done. Certainly, if someone falls and breaks a hip, UNC will take care of them. Someone has appendicitis, someone will take care of them. But in periods where the pandemic has been particularly intense in this area, no one is going to get their knee that's hurting them because it's just worn out and they need a knee replacement. No one is going to get that operation. And unfortunately, what also happens is some of the screening exams, like endoscopies, someone needs a colonoscopy because they might have, they're older and they're at risk for intestinal cancer, that procedure may be delayed as well. So one of the bad effects that we are seeing, it's not just people with COVID that are impacted, it's people with other sorts of routine diseases that can't get the routine care that they need. We're all expecting to see a real bump in the cancer rate in the near future. We have already seen poor outcomes for heart attacks because people are reluctant to come into the hospital. They're afraid that they might get COVID in the emergency department. We're seeing poor outcomes for strokes for the same reason. Both of those are conditions where it's really important, if you're having bad chest pain, that you go to the hospital right then. Because if we're going to melt that clot that's killing heart muscle, we have a very limited time to do that. Or if someone is having stroke symptoms, their speech is slurred or their arm's not working right, it's really important that they go quickly. Because once again, if we're going to take care of that clot that's blocking a small artery that takes nutrition and oxygen to part of the brain, if we don't do that quickly, that part of the brain is going to die. So we're already seeing those poor outcomes. So if you look at the death rate around the country, the expected death rate, we know about how many people will die in a month's time in this country. That has gone up significantly beyond just from those people that are dying of COVID. So it's causing a real impact on some of them. So I guess to answer your question directly, UNC has tried to be flexible. As things get worse, they will contract the services they're able to provide. If they feel like they have a better handle on things, they will expand those services.
We all know people, family or friends, vaccine
Well, how does one convince someone that's vaccine hesitant? I'll give you a few tips about what seems to have worked for me. And most of what I learned is based upon research that was done by a French pediatrician who now practices in Quebec. And in his research, he looked at what was the most effective way to convince parents who are hesitant about vaccinating their newborns or their very young children. And what he found was this. The first step is to really genuinely listen to people and try and understand what their concerns are. The question might be, I hear you saying you're really wondering if this is the right things to do. What keeps you from, what are these concerns? Can you help me understand? So listen to those concerns. Build a relationship of trust with them. The next step is, once that trust is established and you hear their concerns, is to ask their permission to give them information. You don't just start telling them facts. That often just digs people's heels in. Just and then answer as best you can with good information that is phrased in such a way that it makes sense to them. I try to avoid medical jargon when I'm talking to folks in that situation. And understand that this may be a process that takes multiple conversations. It may not happen just then. A shorter technique that some of my colleagues use with people that they've had some success with is just to say, look, you've been coming to see me, Jim, for years to take care of your health. You've honored me by letting you take care of your family. You see my colleagues when their kids break their bones. You let us take care of your mother when she had a stroke. Would you give us that same trust about whether or not you should get this vaccine? Now, that's a shorter interaction, but sometimes especially in emergency medicine, we don't have a lot of time to have a longer extended conversation. And some people have success with that. But people, most of the people have heard all the facts and why they ought to get it, but it is more, as we talked about earlier, it's sort of more this gut level fear of what they heard. It's clear that we have a real pandemic of misinformation. And unfortunately, the way much of social media works, it's this, let's say if you're on Facebook, the information that you get when you look for something, the next thing that they give you to look at is likely to be something that's controversial because they know that that generates more clicks. And more clicks means more ad revenue. So we're having a really difficult time getting out good information. And there are just some people, almost all of them, trying to sell you some product that they're selling, who are giving lots of information as well. Hope that answered your question. Perhaps in more detail than you were interested in, but it's a tough haul. We're down now where there are probably somewhere close to 20% of the people who have not yet gotten a vaccine that are truly hesitant, and the rest of them are pretty hard dug in, and I'm not sure we're going to be able to change their minds. But there are people who are just still hesitant, they're still worried, and there are even people who have a difficult time. I mean, if you're poor and you're having to work 2 jobs to support your family, and you don't have a car, it's pretty hard sometimes just to get to the pharmacy to get this done. And if you think that you're going to have to pay for this shot, which is of course not the case, it's free. Now the hospital or a physician's clinic may charge the government a fee, but it's not your fee. Or some people think that you're going to take information they don't want you to have. I was deployed to Arizona to do some mass vaccination campaigns in an area south of Phoenix where a large percentage of the population didn't have immigration papers. And boy, when you ask for their driver's license, they're out of there. So you just have to make it clear that and at times I've had to remind people, no, you don't. This is not information that we need to be taking. Anybody in this country can get a vaccine. If it's someone that flew in for another country, they're here, we'll vaccinate them. They constitute a risk for us. Other questions? Yes. Yeah, this is a real complicated situation, and it's very confusing. And sometimes I think we haven't done as good a job as we might have in this country about getting information out. Let me just summarize what's available for people now for booster shots. What's available right now is only the Pfizer vaccine. Anyone who has an immunosuppressive condition, that could be because they have a blood cancer or because they're taking a medication that suppresses their immune system, or a number of other conditions, no matter what their age, can go into the pharmacy and say, I have an immunosuppressive condition, I'd like a booster shot. But all they can get for that, they can get Moderna or Pfizer. Okay. So now what recently happened then was the working together, the FDA or the CDC said anyone over 65 who got Pfizer is eligible to receive a booster right now. There's also a large category of people who, because of medical problems that they have or risks that they have, are also eligible. No matter, all the way down to, I believe it goes all the way down to 18. Those would be people, let's say someone who lives in a group home. Someone has a medical condition that causes them to have problems, like diabetes or even high blood pressure. It's a long list. You can go on CDC, you can search that, and find out what those conditions are. If you do work that puts you at increased risk, let's say you're a physician, you're a nurse, you work in a grocery store, there's a law, or you work in a group home, you're eligible to get a Pfizer booster if you had Pfizer. People who live in those group homes are eligible. So there's a pretty long list of other people. So it's to the point where just a whole lot of people are really eligible for these. I don't have the data on the top of my head. You may be able to help me with it, but something like, if you look at people over 40 years of age, there's probably north of 50% of those people have hypertension in this country. They may not know it, but they probably have it. So that makes a lot of people eligible. Teachers, yes, teachers are eligible. Those kind of professions that have increased risk. Now, there is a panel meeting the 28th and the 29th of this month, an advisory panel to the FDA that's going to advise them on what to do about Moderna. And no, I'm sorry, that's the end of this week. Going to advise them what to do about Moderna and Johnson & Johnson. There is also a panel, for talking about dates, that's going to be meeting at the end of this month that's going to advise, and this advisory panel of experts is going to advise them on what to do about kids between 5 and 12. So everyone expects that something will happen with both Moderna and Johnson & Johnson. There's some recent dissension. It turns out Moderna is really not losing much efficacy. But Moderna feels like we ought to get it. So I think the cat's out of the bag, so I suspect something will happen. It's really hard to explain to people, you just got the wrong vaccine, that's why, or you the right vaccine maybe. That's why you're not getting a booster. But we should get some news on that pretty quickly. Yeah, that's going to be a big debate coming up at the end of this week. Johnson & Johnson, as you would imagine, wants to use more of their vaccine, but in a somewhat small study, it actually turned out that the people had better efficacy who got an mRNA, that is Pfizer or Moderna, after their J&J rather than another J&J. So we'll see what happens near the end of this week. So these are tough decisions, and sometimes the data are not as clear cut. The scientific information is not as clear cut, but you've got to make a decision at some point, and it doesn't make sense to keep waiting. The big issue is I think everyone wants to do this in a way that's safe. We don't need people getting sick and dying from the vaccine. That may have. Mm-hmm. I think it's split. I don't know what the ratio is. There are certainly nurses in hospitals, a very few who don't want to get vaccinated. The headline probably ought to be that UNC has gotten 98% or 99% of their nursing personnel fully vaccinated, rather than UNC lets 15 people go. And that's been that way in most hospitals. I can tell you that nurses and physicians, especially those who are on the front lines, like family practitioners, emergency physicians, intensivists who care for people in the ICU who have COVID, this has been an extraordinarily difficult time. And many older nurses and physicians are saying, when this is over, I'm out of here. And some are even saying, I just can't take it any longer. I've got to take care of myself and my family. So we're going to lose some nurses and some practitioners. We're having a bigger struggle getting nurses' aides who care for people in nursing homes vaccinated. But if that's going to happen because so many nursing home patients are in fact paid for by the federal government. And the federal government has made it clear that you can do whatever you want, but if you don't get your staff vaccinated, then you're not going to be getting federal checks. And that has driven a significant number of people to get vaccinated who were hesitant.
Already a nursing.
Yeah.
Before COVID.
Yeah. Other questions? Yeah. 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 We're doing well. Yeah. That's an excellent question. What are the metrics? What measurements do we look at to figure out that we're out of the woods and we can sort of begin moving back into normal life? And there have been various numbers proposed about that. Some people have said, well, we think the best thing to be looking at is the incidence, the daily incidence of disease. For instance, how many new cases per 100,000 population are we seeing on a daily basis? Right now in Orange County, that number is 17. We have been as low as 1 even this past summer. I think most people agree if you get down to 1, especially if you have good case tracing, we can pretty much go back to normal. So 1 case per 100,000 per day. Other people have suggested, well, we really, we're not diagnosing everyone, so maybe that's not a reliable metric. Maybe we ought to be looking at hospital admissions. If those hospital admissions get really low, that's a better number. Now, hospital admissions usually trail people getting diagnosed with COVID by about 2 weeks, and deaths trail by 2 to 3 weeks from the diagnosis. So that's another metric. Some people have suggested testing, and when the number gets 5%, 3% positivity, we're okay. But again, some places are really good about testing and others not so good. So that's not real reliable data. But one of those metrics or some combination of them will let us know when we can begin ratcheting down. And I suspect, having listened to Governor Cooper for a long time, that this is going to be not a light switch, but a rheostat. We'll start turning things down and opening up more and more. And so, yeah, I will tell you that no one has high degree of confidence in their ability to project what's going to happen in the future. We're pretty good at telling about 2 to 4 weeks. There's a consortium called the Hub that the CDC helps manage, and UNC participates in that. And they're pretty good about getting out about a month and projecting what's going to happen. But once you get much past that, it's not as accurate. But when the hub does models of a year, it shows us going down pretty rapidly. And it shows us the number of cases being really low by January. UNC's data looks similar. But everyone has all these caveats that saying, we don't know what this virus has fooled us time and time again. We just need to be closer and see what's going to happen. That's, yeah. Yeah, that is peculiar. It's in Delta especially, but even the other native viruses seem to go in this cycle where they peak for about 2 months and then they start coming down, and it's pretty sharp downturn. Delta clearly has done that. It did that in India, it did it in England, but it doesn't do it everywhere. But it's most places it's about 2 and 2.5 months. I think what everyone's worried about is, okay, what's going to happen in the winter when it gets colder and we all sort of huddle together in more crowded spaces. That's when viruses really proliferate. So we'll have to keep an eye on it. But at least at this point, if I can give you some hope, it looks like that things, the projections at least are suggesting that things are going to be improving. We clearly are, this wave is clearly receding. If you look at the graphs of the number of new daily cases, it's clearly receding. Now, whether what's happened in the United Kingdom, in England, for instance, is what's happened is it's receded, and now it's either plateaued or a bunch of small waves. But they've opened up much more broadly than we have, and they feel like, for them at least, that's tolerable. We need, what will eventually happen is either by enough of us getting infected or enough of us getting vaccinated, we're going to get to a place where we drive the risk from COVID down to where it's acceptable. Right now, at my age, in my mid-70s, my risk of dying from COVID is about the same on an annual basis, is about the same as my risk of dying in a car crash. Now, I don't worry about driving my car. And so at some point, we'll get to a risk that we're comfortable with. Other questions? Okay, at-home COVID tests, or if we could just talk more about rapid COVID tests in general and then narrow that down. So most public health experts believe that a real key to reducing or to getting control of this is having people have the ability to get a rapid test pretty frequently, maybe 2 times a week, or certainly anytime they feel symptomatic, or maybe before they go to a wedding or a big event, or they go visit someone who's immunosuppressed, or go visit their grandmother. It is clearly a priority of Biden's administration that these tests be more broadly available, and money and contracts have been signed, so they'll be easier to get. They've been damn difficult to get. So these will work pretty much like an at-home pregnancy test, basically. So I think you'll start seeing more of those. Now, those tests are not nearly as accurate as the kind of test you would get from some labs, or say you go to a hospital at UNC at Duke. It's a different technology. One is called an antigen test, and the other one is a PCR test, which stands for polymerase chain reaction, but you don't need to know all that. The main thing is that the PCR test is really pretty accurate. Sometimes it's so accurate in finding the virus, it'll continue to show up after you're fine. You're not contagious anymore. But there's just enough virus around that it'll turn positive. The antigen test is not as accurate, but it's really pretty good if saying if you're infectious or not. And that's the real question most of us want to know. So we're going to have home tests available, hopefully for a reasonable cost. Yeah, and hopefully it'll be even cheaper than that. I mean, wouldn't it be great if we had enough tests, if we could, twice a week, we could check our school children and make sure it's okay for them to be going in, and we could do that for $10 a week. That'd be manageable. Well, I think it's probably more likely to be the advisory committee for that is going to meet the end of this month. So I think it's more, and the CDC and the FDA say this is really a priority. So I think it's reasonable that the first part of November we may see approval for that. Yes, that would be my best guess right now. And then for the younger kiddos, it's probably going to be closer to Christmas or New Year's. The data has, the results of the research have not been finalized and presented to the FDA yet for the little guys. Yeah. Well, while kids do get COVID, many of them are asymptomatic. Almost the majority of them are likely asymptomatic. But they do get COVID and they do get sick and some of them die. But it's not a lot. We sometimes have a skewed estimate about how dangerous this disease is to whom. Someone who is 70 and fully vaccinated has a greater chance, significantly greater chance of dying from COVID than a 5-year-old who's not vaccinated. Simply because they tolerate this disease really well, for the most part. It's not to say that we don't need to take care of them, but they tend to do better. Other questions? Vaccines, tests, likely outcomes? I'm probably not very good about the political situation surrounding COVID, but the things involving medicine and science I can likely help you with.
No, there's not enough time has passed to get real good. Are there any partial data that's coming out showing after effects had COVID?
Yeah.
As far as long permanent issues?
Yeah. So if I can just expand that a little bit, let's talk about long COVID. This is a new disease, so we don't really, it just keeps surprising us. Now, there's not even a clear definition of what long COVID or chronic COVID is. The World Health Organization came out with a definition last week. The CDC has a working definition, and the CDC one's a little easier, I think, for most of us to understand. It's saying symptoms in someone who has been infected with COVID or likely infected with COVID, symptoms who persist after 4 weeks for which there is no other reasonable explanation. So that's long COVID. How many people get long COVID? Boy, those numbers are all over the map. I've seen estimates as low as 5% of people who get COVID and as high as 30%. Most of the data seems to suggest that it's people who have moderate or worse COVID that get symptoms, but there's also some studies that suggest that people who have really mild cases get it as well. Now, one thing to understand is this condition is not just about COVID. There are other viral illnesses that likely cause things like chronic fatigue syndrome. And so this just may be what comes part and parcel with having a viral infection. Again, we just don't understand clearly. And the symptoms that people have from long COVID, as most of us call it, are huge. I mean, the most common ones are probably persistent breathlessness, persistent shortness of breath, easy fatigability after minimal exertion, or just a feeling of being really tired, very common symptom. Another one, another symptom would be chronic headaches. GI symptoms are pretty prominent in some surveys. But there's a whole list of things that can be assigned to this long COVID. And I think we're just really trying to figure out what this is. And we're lucky here. There's a clinic at UNC, and I don't know about Duke, but I expect that they have a clinic as well that's really focused on trying to help people with this condition get their lives back. And I forgot to mention what people refer to as brain fog. It's just inability to think clearly. That seems to be a very common symptom as well. Yeah. 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 This is we're going to be trying to figure this out for a long time. It's something that you'd rather not have if you can avoid it. But I think at some point in time, most of us are probably not going to be able to avoid some form of COVID. Hopefully, it's mild and we're vaccinated. Yeah. Yeah, there is a drug that has been developed, and they have submitted a proposal to the FDA. It has this name that doesn't really roll off the tongue well. It's molnupiravir. These antivirals almost always end with the syllable vir. But it is a drug that has actually been on the shelf for a while that appeared to have some real promise. And actually, one of my professorial colleagues at UNC, Ralph Barrick, worked with this a lot. I think then it was called EID 2801, but now it has a simpler name, molnupiravir. But in the studies, what we've seen is in molnupiravir, there was a 50% reduction in hospitalizations or death for people who took this early in the course of their COVID versus those people who took a placebo. So that's not as good as the monoclonal antibodies that can usually be accessed. That's about 80% reduction in hospitalization or death. But it's pretty good, and it's a game changer. No, it's a pill. Yeah, you take. I think.
Well, I mean, I know the current, the new one is
Pill, but
the other one is
exactly right. Yeah, the monoclonal antibodies, which are basically designer antibodies that are made to look like antibodies from people who really effectively fought off COVID. So those have been manufactured, and then you get those by injection. But both of these medications have to be given very early in the disease process. So if you or a family member or someone you know, especially someone who has risk factors, gets COVID, you need to get on the website, Google monoclonal antibodies, UNC, and you'll get a page that'll tell you how to access these medications. The study wouldn't give it to anyone who had symptoms more than 5 days. It probably works even better if you get it earlier. So you've got to get it diagnosed quickly, and then you've got to get a hold of your doctor who can contact UNC or just contact UNC. But work quickly. That's part of what the disaster medical teams have been doing, is going around the country setting up facilities to give people these monoclonal antibodies, because the hospitals have been just so overwhelmed trying to take care of really desperately sick people that they can't do this. So, but UNC has, for a while when they were just overwhelmed, you had to drive all the way to Siler City to get the monoclonal antibodies. This is to the UNC hospital there to get it. But now you can get it multiple places around the triangle. And I'm sure Duke does the same thing. Other questions? Yeah, antibody tests are problematic. They're a problem. There are many types of antibody tests. Most of them don't measure antibodies to this virus well. To do that, it almost takes a research lab to do that. So it's not something that people could go into their family physician's office or their internist's office and say, I'd like an antibody test, and expect to get a result that really means anything. So the CDC at this point doesn't recommend getting those. Now, we know the kinds of people who don't mount a good immune response. We know what kind of diagnoses lead to that, and that's probably the most important thing. And we know what we know what we can do to help those people. You can actually, let's say if someone who has a immune suppressed system, and they know that they got a big exposure to COVID, potentially they could get monoclonal antibody before they even got sick. The problem is there's not enough of that. And so currently, people are reserving monoclonal antibodies for people that have a positive diagnosis, not using it in a preventative way. Also, the downside is, just for the drug itself, costs, monoclonal antibodies cost about $2,100. And the most expensive vaccine is Moderna, and it's around $20. So it's, from a public health perspective about trying to use our funds to help the most people, it's not a good thing to do. Unfortunately, both monoclonal antibodies and molnupiravir have been used by some people to say, oh, well, why do I want to take this vaccine? If I get sick, I'll just take this stuff. Well, I mean, first of all, they're both quite expensive. And second, the vaccine's more effective. So hopefully it doesn't get used that way by It's not the philosophy for many people. But, you know, monoclonal antibodies have been pretty widely endorsed by people who otherwise are vaccine refusers.
Wes, we thank you.
My pleasure.
Talk further and further, but time and your effort and all that you're doing, help and be a part of it. So, thank you.
My pleasure.
Thank you, James. Let you go. I have a choir rehearsal to do that.
Oh, you.